Hello, everyone, and welcome back to the Loop Podcast. I'm Dr. Morgan Martin, your host for today's episode, which is Introduction to Microsurgery. So we are going to start this new series where we bring to you short, fun episodes where we give you an introduction to a certain topic that if you are a junior level resident or maybe an incoming intern, you're going to be able to use these lectures to learn more about these interesting topics, things that you need to know for the job. So here we go. So today is Introduction to Microsurgery. I have with me today future Dr. Greta Davis, who will be graduating soon and also just recently matched at UCSF. So congratulations. I am so excited for you.
Thank you. I'm really excited to be here co-hosting with you today and very excited to begin my training at UCSF in just a few short weeks.
All right, so let's get started. So microsurgery has not been going on for really that long. Dr. Bunke was recognized as the founding father of microsurgery. He was not the first person to do microsurgery. However, back in the 1960s, he did a lot of experimentation in the lab with things such as transplantation and replantation with animals. And so therefore, he is attributed as the father of microsurgery. And since then, we've come a long way with all the things that we can do with microsurgery.
Yes, it's fascinating to reflect on the small jumps that occurred over the past half century or so to bring microsurgery up to where it is today. A little pearl of wisdom for our listeners, the first free tissue transfer is considered to be the groin flap transfer that was performed by Dr. Daniel and Taylor in 1973. This opened the door to numerous studies to define new donor sites in microsurgical transplantations. For the history buffs out there, I provided a link to a great review article on the history of microsurgery, which can be found on our Instagram post or on our visual supplement on YouTube. To dive back into our content, Morgan, what are the basics that I need to know regarding vessel injury and regeneration?
So when a vessel is injured, the intima is disrupted and there is exposed subendothelial collagen. And this causes platelet aggregation and also a thrombotic plug. So this is important to know because whenever you are preparing your vessels for anastomosis, the cut vessel edge has all three layers of the vessel wall exposed. And so for this reason, you must perform a full thickness suture to provide intimal continuity and therefore the highest patency rates. So any exposed subendothelial collagen will increase the rate of platelet aggregation and therefore thrombosis. In terms of regeneration, so the formation of a pseudointima corresponds to the same time frame for the clinical thrombosis. Once that intima starts to heal and therefore form the pseudointima, the platelets are dissipated, and this correlates to the same time frame as when you will usually see thrombosis clinically in your patient.
Great. Now what can you tell me about clotting?
So in terms of clotting, the first step in thrombus formation is platelet aggregation. And so you will see this when the damaged intima has exposed collagen, and this is what triggers that platelet adhesion. Platelets will secrete von Willebrand factor, fibrinogen, ADP, calcium, serotonin, all things that will lead to thrombosis. So our goal is to minimize this platelet aggregation and cascade of events that could lead to thrombosis at our anastomosis.
Which antithrombotic medications are relevant for this discussion on microsurgery?
Some drugs that you may encounter while doing microsurgery. So first, heparin. So this increases antithrombin 3 activity, which in turn inactivates thrombin. Next, we use aspirin very frequently. So this is an irreversible inactivator of COX or cyclooxygenase and subsequently blocks the formation of thromboxane A2. Next, dextran. So this decreases red blood cell aggregation, although the mechanism is unclear. Dextran we do not really use today because there is a multifold increase in systemic complications, including renal failure, pulmonary edema, and congestive heart failure. All three of these drugs have a lack of evidence of benefit in microsurgery. So therefore, we do not use dextran because of the complications, but we still commonly use heparin and aspirin.
That's good to know. So coming back to some more principles of the procedure, how long do we have before we must restore blood flow to the flaps or amputated parts?
So different types of tissue have variable levels of tolerance for ischemia, okay? And so it depends on the composition of the tissue, whether that's muscle, skin, and subcutaneous tissue, or maybe just connective tissue. So the shortest is muscle at 6 hours, and it really depends on the metabolic requirements of that tissue. And so muscle after 6 hours, you're going to have prolonged ischemia and more problems with the microcirculation. Next is skin and subcutaneous tissue. So think about a finger that's been amputated and you are going for a replant. So you have around 24 hours. Connective tissue is the longest and is greater than 24 hours. So just think about once you have prolonged ischemia past these time frames, you're going to have irreversible damage to the microcirculation and the inability to restore flow. Keep in mind that cooling prolongs tolerance to ischemia in all types of tissue, and these numbers can be a little variable depending on that cooling time.
So ischemia is going to inevitably happen, ideally for a minimal amount of time, but what effects on tissue does ischemia have?
So it depends on the type of tissue, because tissue with variable metabolic requirements will have varying tolerance to ischemia. So muscle is the shortest time frame at 6 hours. Next is skin and subcutaneous tissue. So think about an amputated finger that you're going to try and replant, so around 24 hours. And then connective tissue is the longest at greater than 24 hours with a very long ischemia time. Keep in mind that cooling will prolong the tolerance to ischemia for all tissue, and so these time frames can be a little bit variable.
So let's dive down to the microscopic level. What physiologic effects is ischemia having on these tissues?
So with ischemia, tissue will become hypoxic. And with hypoxia, the tissue will start to undergo anaerobic glycolysis, and this will result in local metabolic byproducts such as lactic acid, which this causes cellular acidosis, and therefore coagulative necrosis. This will cause irreversible damage to the microcirculation, and with a prolonged ischemia time, you may not be able to restore adequate flow.
Thank you. So now let's say we've restored blood flow to the tissue or flap. What happens next physiologically?
Once you restore blood flow, you can have reperfusion injury. So this results when you have restored aerobic metabolism, and this results in free radicals and reactive oxygen species. This will cause a localized inflammatory response, which causes leakage of intravascular fluid into the interstitium, so lots of edema. And in prolonged ischemia, keep in mind, just like I said earlier, it may be impossible to restore flow despite an adequate anastomosis and precise techniques.
All right, I think that's a great introduction to some of the physiology behind microsurgery and microsurgical reconstruction. Let's shift gears and talk about some of the key instruments that I, as an intern and other future trainees, should know.
Sure, let's talk about the microsurgical instruments. So first of all, if you are listening to this, you can head to our YouTube channel. We are going to have pictures of the instruments to help you visualize these. But just a few generalized comments about the microsurgical instruments. You want to be careful to not magnetize your instruments. So if you were to have a magnet on the field, you may accidentally magnetize them, and it makes handling the micro needle very difficult. So try to avoid this. You also want high quality instruments that are ergonomic. So now let's move on to some specific instruments. So first, jeweler's forceps. So there are a variety of microsurgical pickups. However, a very commonly used micro pickup is the jeweler's forceps. Next, we have the smooth tip dilating forceps. Okay, these are the dilators. So they have a pointed, smooth, tapered tip. And so these can be used to dilate and intubate the lumen of the artery and the vein whenever you are preparing your vessels. So you want to do this carefully, but they are smooth as to not injure the lumen of the vessel. Next, we have a micro needle driver. One variation is Castro Viejos. We also have straight and curved micro scissors, also known as Westcott scissors. These can be serrated for tissue or non-serrated for suture. Next, we have microvascular clamps or bulldog clamps. These can be single or double.
What else might I see on the Mayo stand during a microsurgical case?
Yes, so other supplies you will need, we commonly use heparidized saline irrigation. So you can put this inside a small syringe, such as a 3cc syringe. You can use a 26 gauge angiocatheter tip. This tip can be used to intubate the vessel and to flush. You will also need a microsurgical background with a contrasting color to help you visualize the vessels to remove them from the surrounding tissue. We also commonly use bipolar electrocautery, microsurgical clips along with the clip applier. We use suction. There are many variations of microsuction and a sterile Doppler.
Great. So could you talk a little bit more about one of the pieces of equipment in the room, the microscope or sometimes your loupes? When do you choose to use one or the other, and what are the benefits and weaknesses of each?
Yes, you can use your surgical loupes to do microsurgery. We also use the operating microscope. Some form of magnification has to be used. So let's talk about the pros and cons of both the microscope and the loupes. So using a microscope, the benefit of this, there is adjustable magnification. You have excellent depth perception, and all the surgeons will have the same full stereoscopic view. So for example, when you're looking at the anastomosis, you know the other surgeon is looking at the exact same thing. There's also a bright light with the benefit of not heating or desiccating the underlying tissue. There's also video capability for the microscope, so this can come in handy. And the magnification of the microscope goes much higher than loupes, so as low as 6 times, but all the way up to 40x. Loupes, they do have benefits of their own. These can have an ergonomic advantage when you're working in a deep cavity or at an odd angle. And there's also reduced operative time because you don't have to worry about bringing in the scope, draping the scope, and getting it set up. So again, reduced operative time could be a huge benefit. You can also do microsurgery when the equipment may not be available. So maybe you're doing a mission, maybe you're at a smaller hospital and the microscope's not available. You can use your loupes and still do microsurgery. The magnification for loupes is 2 times all the way to 8 times, but still much lower than the microscope. There's equal patency rates for vessels that are larger than 1 millimeter. So feel free to use your loupes if you prefer this method of magnification.
Great. Now that we can visualize our surgical field, what type of suture do you use for vessel anastomosis?
So we use non-absorbable monofilament sutures such as Prolene or nylon. The size of the suture is 8.0 to 11.0, and the size of the suture is dependent on the vessel caliber. We will use 11.0 for things such as lymphatic surgery, and then 8.0 for maybe our larger vessel anastomoses. The needle is a micro needle, so it's small, between 50 and 130 micrometers in diameter. It has a sharp, tapered tip and flat body, so the flat body will help it stick inside that micro needle driver and improves the stability when it is held in the driver. If you're doing something such as a nerve coaptation, you're still going to use a small, probably 8.0 permanent nylon suture, but will be dependent upon the size of the nerve.
I've seen anastomotic couplers used in the past. Could you talk a little bit about what these are and when they're used?
A coupler is a device that takes the place of a hand-sewn anastomosis. It is commonly used on the venous anastomosis. It simplifies and expedites end-to-end venous anastomoses, and the patency rate versus a hand-sewn anastomosis is the same. So therefore, like I said, it's commonly used. And if you look at our YouTube video, you can see some example pictures there.
So the coupler looks and functions very differently than suture. Could you kind of walk through how to use the coupler?
Sure. So once you want to use the coupler, so you're going to prepare your veins, you're going to match the size of the vessel diameter. You then pass the vessel ends through that polyethylene ring. You evert the edges of the vein onto the pins and secure them down by using the pusher. You then use the coupling device to approximate the vessel ends, and the interdigitating pins will hold the rings together.
Well, that sounds great, but what are the real advantages of using a coupler?
So the advantage is that it's faster, and yet has the same patency rate compared to hand-sewn anastomosis. The anastomosis is also stented open by that plastic ring. Another big advantage is there is flexibility with vessel size mismatch. So you can have a really large vein put with a very small vein, and you don't have to worry as much about getting that hand-sewn anastomosis perfect to prevent leak. The ring will do it for you, as long as you space out the vessel wall between the pins.
Now, the anastomosis is a really exciting part of the microsurgical procedure, but let's bring it way back to basics and talk first about some things that need to be known when planning preoperatively.
There are a lot of things that you need to think about with your pre-op planning. So first, let's think about the flap choice. What is your defect? What is the size? What is the location? And what is the type of defect? What is the availability of recipient vessels? What is the functional need of the patient? What will the donor site morbidity be? You should make all attempts to minimize the morbidity of the donor site. So think about how this may be important to that specific patient. Next, let's think about angiography. Do we need it for our patient? This can be either CTA or traditional angiography, and you may need it for both the defect or the donor site. So if there are concerns about injured or diseased vessels at the recipient vessel site, then you may need to image these to make sure you have adequate runoff to either the hand or the foot if it is an extremity flap. You can also use CTA to look at your donor vessels to make sure that you have an adequate understanding of the anatomy. Next, you must have adequate debridement. So if this is a traumatic defect or if there's infection, you need to make sure and try to clear that infection as much as possible and remove as much devitalized tissue as possible, which may require multiple debridements. You also need to make sure that the patient is, in the ideal scenario, medically and nutritionally optimized as much as possible.
Sure. So after you've gone through this comprehensive preoperative planning, what are some contraindications that you might encounter or have to consider at least?
Sure. So there are many relative contraindications to free flaps, and this includes patients who may not be fit enough to undergo prolonged anesthesia. Also, patients who may not be able to participate in a lengthy recovery process. Also, you need to think about patients who may not be able to provide adequate consent for the operation. Are they the right candidate for microvascular reconstruction?
Which patient comorbidities or factors should we be aware of as having a higher risk of flap loss or complications?
So let's start with age. So age alone is not a contraindication. So micro has been shown to be safe in both elderly and children. And there's no difference in flap failure or complications. We also need to talk about diabetes. So we are all hesitant to do surgery, especially microvascular surgery, on diabetics who have a high A1C or have their diabetes out of control. It is unclear whether flap outcomes are affected. However, we do know that perioperative glucose control reduces overall complications. So this includes surgical site complications such as infection and delayed wound healing. And although we do know that diabetic patients do suffer from distal microvascular disease, this does not equal increased flap-related complications for those patients, like I said before. The next to mention is obesity. So we know that in obese patients, flaps are 2 times more likely to fail compared to non-obese patients. However, the overall flap failure is still low. And so for this reason, we know that performing free flap reconstruction in obese patients when it is indicated is actually still better than the non-microsurgery alternatives. Also, smoking. So, yes, we are hesitant to do microsurgery in patients who smoke. We do advise patients we want them to quit smoking 4 weeks before surgery. However, there's no evidence that smoking reduces anastomotic patency. But it does increase complications such as wound healing, skin graft take, infection, flap necrosis, and that would be a partial flap necrosis or fat necrosis, hernia formation, and length of hospital stay. Let's also mention specific comorbidity, patients with lupus. Patients with lupus can be hypercoagulable, and this is due to lupus-specific factors such as antiphospholipid antibodies, and the inflammation associated with lupus can also increase certain procoagulant factors, and in addition, they have platelet hyperfunction. So any patient with a history of lupus, I would just be careful and make sure and discuss with them the risk of undergoing free tissue transfer and come to a conclusion on how you want to anticoagulate the patient perioperatively.
Before a microsurgical procedure, internationally recognized microsurgeon Dr. Frederick Kolb at UCSD always says, "Comme on fait son lit, on se couche," which means, as you make your bed, so you must lie in it. Morgan, can you walk me through some technical pearls for setting yourself up for success before and during the procedure? And for our French-speaking audience out there, you'll have to pardon my pronunciation.
So we can think about surgical precision as the key to microsurgical success. So precision should equal patency. So for this reason, we need to think about being comfortable while we are operating. So first, you want to think about an ergonomical setup, and this is what will lead to success. So make sure and set up to where you're the most comfortable, to where you're standing in a comfortable position. Your neck and shoulders should be relaxed. Your forearms and wrists should be resting and supported. This may include stacking surgical towels in order to prop up your wrist. If possible, you want your body to be parallel to the long axis of the vessel. Obviously, this is not possible during many of our operations. However, this would be the most ergonomic and easiest way to perform your anastomosis. So if at all possible, position your body parallel. You also want to think about getting wide exposure before you start. You may need to further mobilize vessels during your operation, and if you have wide exposure, this will be easier. You also want to avoid working in a hole if possible, although we do know sometimes this is not possible to get around. And you also want to prepare your recipient vessels completely prior to dividing that flat pedicle. So you don't want to be on ischemia time with any pressure. You want to just be able to have your vessels prepared, and as soon as you divide the flap, you can start working on your anastomosis. You also want to sharply excise that periadventitial tissue. So remember that any of this adventitial tissue, if it happens to get inside of your anastomosis, this can be thrombogenic, so make sure and sharply excise this. You also want to go ahead and make sure and clip all those side branches. And before you start your anastomosis, make sure and irrigate with heparinized saline to remove any intraluminal clot that may have formed. Next, you want to make sure and take care of that pedicle. Always check for any twisting, kinking, compression, or any tension on the anastomosis. While you're preparing the vessels, you want to dilate the artery with the smooth tip forceps, putting the tip of the forceps into the lumen, but you want to avoid doing this repeatedly as you can damage that intima. Before you begin your anastomosis, you want to release the clamp and check for forward flow. Make sure you have good inflow and again, flush with heparinized saline. You then want to apply the double opposing clamp to approximate the two cut ends, both your donor and your recipient vessels. And then you're going to perform your anastomosis in that tension-free intima to intima apposition. Keep in mind, if there is any tension on the anastomosis, you should be using a vein graft. And there is no difference in patency rates for the vein graft, so use this if you need to.
Can we go over the different suturing techniques?
Yes, so let's start with talking about the variations on technique. So you can do either simple interrupted suture or a continuous running suture. So there is no difference in patency rate. So really the determining factor for this is surgeon preference and also the clinical scenario. So keep in mind, so interrupted suture would be preferred if, say, there is a large vessel size discrepancy, because you can space out those interrupted sutures in order to accommodate for the larger vessel. And then with continuous suture, there's less knot tying. So this is potentially more time efficient. And also with a continuous suture, you have the advantage of distributing the tension equally along the suture line. Now, we can also do an end-to-end versus an end-to-side anastomosis. So again, some of this is surgeon preference, some of this is clinical scenario. Keep in mind that an end-to-end anastomosis is usually appropriate for most arterial and venous anastomoses. However, an end-to-side anastomosis may be necessary if you are doing a limb reconstruction and need to maintain distal perfusion, or also if there is a very significant size mismatch. Keep in mind, end-to-side anastomoses can be more difficult, so usually this is why an end-to-end anastomosis is preferred. Now, a few specific comments regarding technique. So you want to hold the needle at the halfway point, and you want to place the most difficult suture first. You want to enter the vessel wall perpendicular. And of course, we are going to include all 3 layers of the vessel wall. And you want to enter the vessel at a slightly larger distance than the thickness of the wall. So I know personally, especially when I first started, I was always unsure about exactly how far back on the vessel should I place my needle, but this is a good rule of thumb, slightly larger than the thickness of the vessel wall. Of course, you want to always visualize the tip of the needle at all times. Remember, any damage to that intima is going to increase your risk of thrombosis. To orientate yourself, you can use a bisecting suture, and you want to place your sutures at equidistance along the vessel. Of course, you want to pay special attention to avoid the back wall of the vessel. While you are doing this, you can use your jeweler or smooth tip dilator forceps to assist you when you're placing your first stitch. Going from outside to inside the vessel, you can use the forceps on the inside of the vessel for counter tension to press against the vessel wall, again, taking care not to damage that intima, and using it to visualize the tip of the needle. Then on the other side, so from inside to outside on the other side of the vessel, you can again use those forceps to provide counter tension to push that needle through the vessel wall. You want to make sure and not do repeated attempts. This, again, can damage the intima. You want to visualize exactly where you want to put that needle and push the needle across without having to repeat any sticks or attempts. Otherwise, you may have to revise your anastomosis and trim back any damaged intima.
All of that really sounds easier said than done. So let's say we have our anastomosis complete. What comes next?
So right before you place your very last stitch for the anastomosis, you want to flush with heparinized saline. You will then open the venous clamp first, then your distal arterial clamp. This will let some blood flow back through and will allow you to repair any leaks. You will then release the proximal arterial clamp. You will then look at your anastomosis, and in order to reduce spasm, you can apply some topical medications such as lidocaine, papaverine, or warm saline.
And whoops, we've got a bleeder. What do we do?
First, you want to look for unligated side branches. Okay, so obviously these are going to give you some bleeding, so make sure and clip those if you haven't already. You're then going to look for a second outflow vein. Maybe you left one open from the flap side. Go ahead and clip this, unless you're worried about your vein, of course. At least clamp it. Then you want to look at the anastomosis itself. You may need to reclamp the artery to cut off the flow in order to get a better view, in order to maybe place an additional stitch if you have significant bleeding.
What are the critical things to look for to make sure you have good patency or flow?
So for good flow, so you want to look at patency. So is the artery pulsatile? Obviously, it should be pulsatile. You can check with your Doppler if there's any question. The vein should be full and maroon. The flap should be returning to good color, and there should be bleeding from the edges of the flap. So you may want to wait 3 to 5 minutes if maybe there was some spasm. As I said before, apply those medications such as the lidocaine and papaverine to see if that helps with the spasm. And after 3 to 5 minutes, let's check for adequate patency. After those 3 to 5 minutes are up, we can look for patency. So like I said, the artery should be pulsatile. And if there's any question, we're going to check the vein by doing this patency test. So first, you're going to include the vein distal to the anastomosis. You are then going to use a second forceps to empty the blood, so push it out downstream and then hold it there. Then you're going to release the proximal forceps while keeping that distal compression, and then you're going to observe for blood return through that anastomosis, filling that distal vein. If the vein fills, then that means the vein is patent.
All right, you've waited 3 to 5 minutes, you've done your patency test, and you still aren't finding convincing flow. What's next?
If there is no flow, first you're going to check for some simple mechanical things. So check for kinks to the pedicle, any twist, any points of compression. You may have to release whatever closing you have previously performed over your recipient vessels. Next, you may just need to leave it alone for 15 minutes. Maybe there's some spasm. If there is still no adequate flow into the flap, you're going to need to excise and redo your anastomosis. If you have repeated thrombosis, you can try using thrombolytics such as TPA, tissue plasminogen activator, within the flap itself.
Thinking back to some of the preoperative factors that can impact flap survival, what do we need to know if a patient has been irradiated in the area of surgery?
So with irradiated vessels, keep in mind these vessels are going to be fragile, they're going to be atherosclerotic, fibrotic, and the intima is much more likely to be injured, so you just have to be extremely careful. Sections can lift away from that intima, and any sections that lift away like that, they are highly thrombogenic. So if there is any injury, you must trim back all of this area of vessel. So keep in mind, this may mean that you have to trim back adequately and use a vein graft. And if we look at the literature, so there's actually conflicting studies on whether flap loss is higher in irradiated vessels. Now, just like I was saying, it is more difficult to handle these vessels, but we do not have evidence that for sure flap loss is higher.
There must be some intraoperative factors that are important to maximize flap success. What should I know about anesthesia care?
So a few generalized points for anesthesia. So you want to maintain adequate circulatory volume. So this would mean an adequate MAP or mean arterial pressure and adequate cardiac output. And this is important for flap perfusion. So just having an adequate MAP is going to increase regional blood flow and microvascular patency. Vasopressors, so I know all of us hate using vasopressors. Still, we out of habit always tell anesthesia, please do not put our patient on pressors. However, there's actually no evidence of increased flap loss. And there are some papers that actually argue that they could be beneficial. And so this argument is based on the fact that if your patient does need a vasopressor for adequate MAP, putting the patient on a vasopressor means the patient's going to have a higher MAP, more flow, and if you think about how we prepare the vessels, that adventitial stripping denervates the vessels. So technically, they're probably immune to having an effect by any of these vasopressors systemically. So next, in terms of temperature of the patient, you want to avoid hyperthermia. Of course, hypothermia will lead to vasoconstriction. And in order to avoid this, you can do things such as using a forced air blanket, warm IV fluids, humidified and warmed anesthetic gases, and increased ambient room temperature.
Great. So we've talked about preoperative planning. We've talked about the procedure itself, some keys to optimize flap success. Now, let's say the procedure is finished and we've got the patient in the PACU. What are some key components of postoperative care?
So post-op management is very important for free flaps. You want to make sure and have no pressure on the flap. So this may mean minimal dressings. You don't want there to be any potential for these dressings to put pressure on the flap. So less is more. And it also means that you can visualize the flap better. And this is important for maybe the nurses who are coming around every hour to visualize the flap, or for anyone who may be stopping by to check on the flap. We want to be able to see the entire flap. So minimal dressing, less is more. In the post-op period, you also want to maintain adequate MAPs, as I said, for the intra-op period. So same for post-op, adequate MAP and adequate urine output. And so fluids as needed for this purpose. The hematocrit needs to stay between 25 and 35%. Those that like to use hemoglobin, this would be 8. And this may mean that you transfuse the patient more than you normally would for your surgical patients. So usually we transfuse at 7, but in this scenario, we should need to start thinking about transfusing at 8. Obviously, patients need adequate pain control and, in general, no nicotine or caffeine. But as we have said before, in terms of nicotine having no increased flap complications, this is really for post-operative surgical site complications.
Should we be using or thinking about antithrombotics postoperatively?
So speaking about antithrombotics, now, we do not have evidence that either aspirin or heparin offers protection from microvascular thrombosis. Again, no evidence for this, but we still use it. There's minimal risk to the use of these medications. Of course, therapeutic heparin would have a potential increase in bleeding, so use with caution in that scenario. So typically, most patients get aspirin postoperatively starting immediately after surgery and then daily. And heparin, we usually only put them on a standard heparin regimen if there is concerns about the flap, if you've had a thrombosis, or if there's any other reason why you're afraid that the patient may have an increased risk of thrombosis. Now, keep in mind, these are surgical patients, so if you are not giving a therapeutic dose, you still need them on a prophylactic dose of Lovenox or heparin.
Now, flap checks are a key piece of the postoperative order set. Can you talk to me more about postoperative monitoring of a flap?
So keep in mind, thrombosis is most common in the first 24 hours. And during that first 24 hours, anastomotic imperfections and pedicle positioning is the most common reason for thrombosis. So if there is any question about this flap, it can be saved by exploration and revision in a timely manner. So any question, you need to be going back promptly to the operating room. And in terms of monitoring, standard of care is still clinical evaluation. So you're going to be looking at color, capillary refill, turgor, temperature of the flap. If there's no arterial flow, the flap is going to be cool, pale, and have a lack of cap refill. Venous thrombosis, there's going to be a rapid capillary refill, swelling, and purple discoloration. So think about, you still have arterial flowing into it, but no drainage of the flap. So it's going to be swollen and purple. So in terms of monitoring devices that we're going to use, so handheld Doppler ultrasound. If you have a skin paddle, you can use this on the skin. If there is a buried flap with no skin paddle, you can use an implantable Doppler probe. Other things that are being used, so surface temperature measurements. If it is a digit, such as a replant, it can be just a simple pulse oximeter on the tip of the digit. We can also do transcutaneous oxygen tension monitoring, near-infrared spectroscopy, intravenous fluorescent angiography, pH measurement, interstitial fluid pressure, and reflection plethysmography. In general, now there is a wide variation in this depending on where you're at, your clinical experience, but in general, flaps should be monitored every hour for 48 hours, and this is usually the nurse visualizing the flap and doing a flap check, and then the physician can be monitoring maybe at a distance, or like I said, there is a high variation on post-op monitoring. At my institution, we always visualize the flap within 6 hours post-operatively. And then after 48 hours, you can push out monitoring to every 2 hours until the 5th day. And then after day 5, you can move to Q4 hours until discharge.
What if a problem with flow is encountered in the post-operative period?
So if you encounter a problem with flow, you want to first look at correctable issues such as patient position. Is the flap dependent? Is there compression on the flap? Is there any constrictive dressings? You may need to release the inset sutures. This may be compressing on the pedicle. If there's any question, you need to return to the OR immediately because an arterial signal can persist for hours with a venous thrombosis.
If ultimately the decision is made to take a flap back to the OR, what is going on in the operative room?
So first you want to inspect the anastomosis. You want to take it down. You want to give the patient 5,000 units of IV heparin. If there is a clot at the anastomosis, you want to perform a mechanical thrombectomy with a Fogarty catheter. You want to remove the entire clot. This is very important because that clot can be a source for additional thrombus or microemboli. This clot can travel downstream and occlude the flap distally. You want to trim the vessels back to pristine intima. You can also use a thrombolytic agent within the flap with the flap occluded. So this is not systemic. This is not IV. It's only within the flap. So you can use streptokinase, urokinase, or TPA. And keep in mind, you may need to change recipient vessels if this was part of the problem.
And this wouldn't be an effective talk on microsurgery if we didn't bring up Sandom's favorite topic, leeches.
So let's talk about those leeches really quick. Keep in mind that leeches should be used for venous congestion despite a patent venous anastomosis. This does not replace exploration of your flap in the operating room, okay? Keep in mind, leeches also will fall off at satiety, so you will have to replace them. You can't just order one leech and then expect to put one leech on and it fix the flap. So you need to replace them as they fall off. Leeches also have growing in their gut the bacteria Aeromonas hydrophila, so the patients need to be put on prophylactic ciprofloxacin. Keep in mind, if it is a child, you cannot use ciprofloxacin, so you have to use a third-generation cephalosporin. So next, let's talk just a second about flap failure. If you have a failed flap, you want to debride this as soon as possible because any necrotic tissue is just going to cause a systemic reaction potentially with the patient, so you want to remove that as soon as possible. You can temporize the wound. This may mean placing a skin graft, placing a wound vac, or potentially even doing local regional or a second free flap. So thanks, Greta, for helping me get through this lecture.
Thanks for having me.
And I hope this was beneficial to everyone out there, especially our junior residents that may be coming into the time where they may need to use microsurgical skills. And for our incoming interns, I'm really excited for all those who have matched. And we will continue this intro series in order to help bring everyone up to speed with everything they need to know about basics in plastic surgery. If you like this podcast, I want everyone to go and subscribe to us on both our YouTube channel and wherever you get your podcast. Leave us a rating, give us a comment, let us know what you want to hear from us, and make sure and also find us on Instagram. We will be continuing to update all of our followers with this content for plastic surgery education. Follow us to Get in the Loop.